We are very pleased to welcome Renee Gilsonen, Rhonda Schwartz, and Iris Gutmanis to speak about the development of the Patient Experience Survey for Specialized Geriatric Services in Ontario and to share some steps for implementing this tool. Our speakers today have deep experience in this topic area. Renee Gilsonen is the Program Evaluator for the Regional Geriatric Program of Eastern Ontario and co-chair of the RGPs of Ontario Performance Measurement Committee. She is also the primary investigator for the development and validation of the RGPO Patient Experience Survey. Rhonda Schwartz is the Director of System Planning, Implementation, and Quality at Seniors Care Network in the Central East Lynn. She is also a co-chair of the RGPs of Ontario Performance Measurement Committee. And just a note that unfortunately Rhonda has lost her voice today, so she won't have a speaking role in the presentation, but she will be present in the background. And finally, Iris Gutmanis is an associate scientist at the Lawson Health Research Institute in London, Ontario, and adjunct professor epidemiology and biostatistics in the Department of Psychiatry at Western University. Her current area of research includes geriatrics and mental health. Before we get started, I'd like to let you know how to engage with our speakers today. They will answer questions at the end of the presentation, but we encourage you to type them in the chat box at any time. And I'll start by answering the most commonly asked question: can we have a copy of the slides and video for this webinar? And the answer is yes, you can. We'll send them to attendees and post them on our website. And with that, I'd like to invite our speakers to take the stage.
Thank you, Wendy. So this is Renee Gilsonen, and I want to first off thank the RGPs of Toronto for inviting us to present today. We're very excited to be here. So I am just going to share here we go. There we go. Share. Oops. Uh-oh. Crumbs. Sorry. Oops. Oh. This wasn't supposed to happen. 1 second. There we go. There we go. All right. So again, this is Renee Gilsonen, and good afternoon, everyone that is attending today. So I'm going to be starting this conversation, and Rhonda won't have a speaking part, but she is listening in, and Iris Gutmanis will also be involved in this conversation with you. So we'll be talking today about patient experience survey for the Specialized Geriatric Services in Ontario, and we're excited to do so. So first off, Rhonda and I co-chair the RGPs of Ontario Performance Measurement Committee and the Patient Experience Working Group. Neither of us have received any additional payment or funding to do this work on the development of the Patient Experience Survey. However, we were able to secure some funding for Iris Gutmanis, our epidemiologist, to conduct a rigorous analysis of the pilot survey data, and that's noted here. So who we are. So the Regional Geriatric Programs of Ontario, if you don't know already, is a collaborative provincial network. We support specialized geriatric service delivery, capacity building, evaluation, and advocacy in Ontario. And when we say SGS, we mean those that assess and treat functional, medical, and psychosocial aspects of illness and disability in older adults. And we have multiple complex needs, typically work in collaboration with primary care physicians, community health professionals, and others, and work in various community settings, acute care, and primary care. And with the RGPs of Ontario, together, we work to meet the health needs of the most frail and vulnerable seniors. All right, so I just wanted to talk about that. Okay, so the learning objectives for today. So the idea is that by the end of this webinar, that you'll have an understanding of the need for provincial patient experience survey, one that's designed specifically for specialized geriatric services. So an overview of the steps taken to develop and test the patient experience survey, and a summary of the learning and next step. All right. So this is for patient experience. This is the next part we're going to talk about. Before we do so, though, I would like to do a poll for those of you that are listening. And so maybe we could put that poll up now, Wendy. Perfect. So which type of survey are you most familiar with? Patient experience, patient satisfaction, or neither? So if you could enter your responses at this time, that would be great. Just waiting a little longer here. All right. Okay, so the results are in. 75% they're most familiar with patient satisfaction, 20% patient experience, and 5% neither. So that's really great. Okay, thank you very much for getting involved in the poll. So there we go. That's very exciting. So let's talk a bit about patient experience versus patient satisfaction. So these terms are used interchangeably, but there's a difference between them. The setting provides the context for both patient experience and patient satisfaction. However, where they differ is that patient experience, you're typically asking more what happened versus patient satisfaction, where you're looking at more how do we do. So there's more of a little bit more subjective measure with patient satisfaction. You aim a little bit more with patient experience for more objective measures. However, there are still subjective aspects to that. Again, all of this is seen through the patient's eyes. So the biggest part of this is that patient experience is considered easier to fix, more objective, easier to identify quality improvement initiatives. So benefits of accessing patient experience, we've got these benefits for patients, for healthcare providers, and overall healthcare system. So what I'd like to do first is talk about the benefits for patients. So it can lead to safer clinical experiences for patients, and with increased engagement, you get better clinical outcomes that can be achieved. For example, an enhanced adherence to treatment, in treatment plans, medication use, that kind of thing. Again, these statements are all based on research, and so you'll see that the little footnotes are there. The resources, the references are going to be provided at the end of the presentation, so you'll see them at that time. All right, next slide. So healthcare providers, the benefits to them, so there's an opportunity to innovate. Greater employee satisfaction, reduced turnover, all these things are great. And at the healthcare system, the survey supports enhanced strategic decision-making, performance monitoring, and benchmarking, and the ability to identify both local and system-wide issues. Okay, so those things were all great. So, but then let's look at this. We just sort of talked about patient experience in general, the value of it, but now it's why do we need one specifically for SGS? Okay, so what's the problem? So the problem is, so at the beginning of our work, of the working group, I should say, a review of available patient experience survey revealed that reliable and valid patient experience survey for specialized geriatric services just did not exist. There wasn't one. So because of this, geriatric patients in Ontario have had really very few opportunities to collectively voice their concerns and to shape healthcare. So without one provincial patient experience survey that is reliable and valid, there really is no way to roll up patient experience outcome data from the program level to the regional level or to the provincial level. And regional and provincial funders are missing out on, really what geriatric patients accessing SGS have experienced. What works, what doesn't work, they don't have that information. And other organizations do have that. So whether it's cancer care or like you've got other sources have that. And if we had that, we'd have a much larger voice for patients in Ontario. All right, so what I want to look at here really are the challenges with available patient experience surveys. So when we were preparing for this, again, we reviewed all these different patient experience surveys. We looked at regional, provincial, national, international ones. And it really revealed that, again, there isn't one that really fits for SGS. For example, typical patient experience surveys align with specific healthcare sectors. So with that, I mean acute care, so hospitals, primary care, home care, long-term care. or they were designed with one condition in mind. However, when you look at specialized geriatric services, they're cross-sectoral. Patients, so it's, you know, their services are provided in acute care, primary care, home care, long-term care. And if there's just one patient experience survey that's going to cover all of those areas, then there just really wasn't anything. And the other challenge is that, you know, the patients that access SGS, they have comorbid conditions. So there isn't just one condition in mind. It doesn't really work. The other part of it too is although rehab does play a large part for SGS, not every specialized geriatric service does have a rehab component. And we're really looking at a core set of questions that could be asked for all programs across the province. So the response. So the RGPs of Ontario collaboratively developed a core set of survey items, and we wanted ones that were evidence-informed, valid and reliable, designed specifically for appointment-based SGS, designed to obtain the perspective of the patient only, and designed for patients who were able to provide verbal or nonverbal feedback. Okay, so let's break this down a little bit. At the top of the screen there, you see developed a core set. So when we say core set, we mean the minimum set of required survey items, or what you call survey questions, to be measured and reported on that should fit for all appointment-based SGS programs. Okay, so what does appointment-based mean? Okay, so we mean those programs where patients are scheduled for an appointment versus care that's not scheduled. So care typically isn't scheduled in emergency departments, inpatient, long-term care. So those ones are not included, really, they don't really fit for what we're developing right now. In the future, we may have that, but at this point, the core items we have are for appointment-based. Okay, so and when I say designed for patients who are able to provide feedback, either verbal, nonverbal, on their own, or with assistance from a family member or friend, we have to remember that this is a patient experience survey. Therefore, we want the patient's perspective, not the caregivers. It should never be completed by a caregiver alone. It must be collaboratively completed if a caregiver needs to be involved at all. All right. Survey development processes. Okay, give you some details. So timelines. So the project began way back in June of 2015. And so 4 years ago, and it had 3 phases. So phase 1 is the preparation phase. It's where we were establishing a committee, lit review, identified framework that we could use, and drafted some core items, involved the research ethics board. Then the phase 2 is where we did the patient engagement, patients and caregivers were engaged, and phase 3 was really the testing phase, and where we had pilot testing and then psychometric testing of the survey items themselves. So I'm going to break each one of these down, and sort of in this methodology phase, I'm just going to go through it, and then I actually break down and go into even more detail after this. So for phase 1, regional and provincial SGS experts were engaged from across the province. We wanted individuals that were skilled in clinical methods, research, performance measurement, and evaluation. So members of the working group selected and then utilized a collaborative decision-making method to support decision-making throughout all phases of the work. And then, after reviewing the literature and available frameworks and surveys, so a nationally recognized evidence-informed patient experience framework was selected and adapted to underpin the selection of the Specialized Geriatric Services survey item wording, so the survey questions. And then we identified some draft survey items. We had something to start to work with. Each one of those aligned with the framework. And then, this is all still in phase 1, a research protocol was developed and submitted to 3 research ethics boards from across the province, and we received approval at all 3 sites. So we then, phase 2, we moved into that phase. That's patients and caregivers who had experienced SGS were engaged from across the province to participate in cognitive interviews. And as a result of these interviews, the core items were refined. And then in phase 3, the refined survey was pilot tested at 2 provincial sites, and core items were further refined. And then we brought in an epidemiologist, so Iris Gutmanis, who was engaged to conduct psychometric testing on the survey to analyze the validity and the reliability of the measure. And the survey core items were further refined even after that. Okay, so in phase 1, the working group built off the scoping review conducted by Sabrina Wong and Jeannie Haggerty. So they did this work back in 2013, and Wong and Haggerty's work informed the composition of core primary care patient experience survey items for use across Canada. Their scoping review was conducted as part of the Canadian Institute for Healthcare Information, so CIHI, their primary healthcare survey project. So their evidence-informed framework was selected by our working group as specialized geriatric services and primary care have many aspects in common. So from appointment-based services to comprehensive care, there were a lot of things that aligned. There were a couple of things that didn't align, and some of those subdimensions, I think there was one subdimension or two that were removed because they just didn't align. Say comprehensive care, where in geriatrics, you provide care. For the most part, it's not for the lifetime of a patient, which would fit in more with primary care. All right, anyways, this slide here, so it gives you a look at the dimensions and the subdimensions that are part of the adapted framework, and that underpinned the work that we did on developing those core items. All right, next slide. So the key principles that, there were 4 of them, that we utilized when developing and refining the wording for the core items throughout the project. So there was clarity, simplicity, contextual specificity, contextual relevance. I mean, ultimately, we had to think about the reading level, so the grade 6 reading level, for patients and caregivers to make sure they could, that it made sense to them. And we need to make sure it worked within multiple settings for SGS, and whether someone was visiting a home or a hospital, and whether there was one provider or multiple providers. All of these added to the complexity for building the survey. And also throughout the work that we did in all 3 phases, a modified real-time Delphi methodology was utilized. So we held teleconference meetings with members from across the province, and this structured decision-making process supported the collaborative approach we needed for this project. Working group members received round after round after round of structured questionnaires and worksheets to support decision-making regarding core survey item wording. So we had voting that occurred throughout, and then detailed notes well beyond any minutes went, because these were 1.5 to 2 hour meetings that we held. And then all those information about the decisions and why we made them were then forwarded so that we could say, this is why we made these decisions. And then further discussions would happen, and it would start again. All right. So cognitive interviews. So this was really about phase 2. Patients and caregivers participated in cognitive interviews at 3 sites from across the province, and this enabled us to examine potential sources of response error in the survey. So the 3 sites were the Scarborough Ruse Hospital Gain Clinic, the Ottawa Hospital Geriatric Medicine Ambulatory Services Day Hospital, and the Northeast Specialized Geriatric Center. So we needed to make sure, we needed to bring it to the patients themselves and really get a sense from them as to, were there any potential sources of response error in the survey? We needed to make sure that the final wording made sense to those patients and that it captured the intent of the framework. We needed to know, were we missing anything? Did they think that there were any aspects of patient-centered care that were missing? So often survey wording is based on what a clinician thinks a patient would understand, but we went straight to the patients to figure out what was appropriate to them. The feedback was then themed and informed the final decision with regards to that would be pilot tested. All right, so now let's talk about pilot testing. So we pilot tested the draft core survey items. The draft survey was pilot tested at 2 sites across the province. So the Ottawa Hospital Geriatric Medicine Ambulatory Services Day Hospital Program, boy, that's a long one, and the Scarborough Rouge Network Geriatric Assessment Intervention Team Network, or GAIN team. And the pilot ran from February to July of 2018, and a total of 145 surveys were completed. Okay, so what actually is the content of the survey that we pilot tested? It included the following aspects. So the date the patient completed the survey, exactly who completed the survey. So was it the patient alone, or was there someone else that helped them? And then there were 16 core items, so of which 12 were based on the evidence-based framework and focused on patient-centered care, 1 related to overall care, 1 related to the willingness to recommend, and 2 qualitative items regarding the strengths and areas for improvement. And survey format. So for the pilot testing version, we had 1 page. It was like a legal format. To make it easier for seniors to read the survey items, we used 14 font. And as I mentioned earlier, the draft core set of survey items was worded at a grade 6 level, and the pilot survey was available in English only and paper only. So when we talk about paper, we use a paper format only, meaning it was not tested using any electronic or online software. So what this ultimately means is that we will want to go back at some point to implement an electronic or an online version. Then best practice would have us go back and follow the same process to validate the survey. So, oh my gosh, REV approvals, pilot testing, analysis. So we will get there, but it's a process. All right, so pilot site instructions. So it was important that each site receive the same instructions. We met with leadership of the programs where the pilot testing was to be conducted. We reviewed the survey content with them. We went over topics for expectations for staff education and methods for data collection. And we also wanted to receive agreement from the leadership that the pilot survey would not be changed in any way. And for so many reasons. Anyways, I'll get in that. But we asked them to provide details on changes that they recommended following the pilot so that we can improve the survey's applicability to SGS, but later on, not during the pilot. We couldn't make any changes to it. So the content that was to remain the same during the pilot, the wording of each of the core survey items or the survey questions, the survey response scale, the introduction to the survey, who completes the survey, that particular question, and the survey instructions themselves. And so again, that whole thing about how it was important that they used and stayed true to the draft wording. It's so, there's such a tendency to want to change the wording so that, you know, tweak it a little bit so it feels like it fits your program better. But the problem is if the wording was changed, the entire pilot project would have to be redone. So they had to agree to that. And so the only elements that could be added by a pilot site basically was the site, the logo, the site logo, and the program name in the introduction. That could be inserted. And then in one of the actual survey items, there's a space for program sites to add their program name as well. And then prior to the distribution of the surveys at each of the pilot sites, staff received information about the survey development process, how the survey was to be distributed to the patients, and how the surveys were to be collected. All right, so I'm going to pass this over to Iris Goodmanis to get into the quantitative and qualitative data.
Thank you, Renee. Good afternoon, everyone. As an epidemiologist, I'm somebody who really enjoys looking at numbers and quantitative data. So that's how I got to be involved with this particular project. So what we're going to be talking about in the next few slides is results from the phase 3 pilot testing. So as you've heard from Renee, that the tool included both numbers, quantitative data, as well as comments, qualitative data. So I'm going to speak to the actual way that we did the analysis, but please note that I'm not actually going to be providing the real numbers that we collected. We're hoping to do a publication, and we need to save those exact numbers and the exact results for that particular, for the publication. So now I'm going to talk a little bit about sampling. So the very first thing is how many people do you need to recruit for the study? How many people actually need to fill out that survey tool? There's a number of online sample size calculators, and I put the first bullet as the actual sample size calculator that I used. And to actually calculate your sample sizes, you need three basic pieces of information. What's your confidence level? And you may have heard people talk about 95% sure or 99% sure. You have to select a confidence interval. Do you want to be plus or minus 5%, 7%, 10%? And then the number of people you need to speak to is also a function of how many people are seen over the course of the year. So the next slide shows you a lot of numbers, and I'm not trying to give you a primer on sampling or anything crazy like that. But before I actually said to each of the sites, you need to see X number of people, I generate these kinds of tables to just sort of say, what can we do with these numbers? So that the table on the far left-hand side says, let's look at a 95% confidence level, and let's look at the impact of altering different confidence intervals. So if we wanted to be plus or minus 5% in the site that saw 600 people, we needed to see 234 people. In the site that saw 3,000 people, to be plus or minus 5%, we needed to see 341 people. As you can see, generally speaking, the site that had 3,000 people needed to see more people to get a representative sample than the site that saw 600. So then the next thing I did was, as I said, what if we switched it to 99% confident? I want the confidence level to be really tight here. So that's the table or the numbers that are on the far right-hand side. So what you can see generally there is that you need even more people to be more confident. So when I looked at these numbers and went back to the sites and I talked to the places, and it was sort of like, could you see 230 people filling out this form over the course of whatever? So what's reasonable and practical at your sites? And so when we actually looked at these numbers, what ended up happening was, is we said, let's do plus or minus 10%. So to see roughly 80 to 90 people at each one of the sites, most of them said, yep, that kind of is going to work for us. So what ended up happening is we started the data collection in February, finished in one site, in March in the other. But as you can expect, by about May, the clinician said, do we have to send out the survey again? And so what I said is okay, so usually 50% of the sample size is also a function of the percentage of patients who select a particular response. Frequently, you don't know, are 50% of people going to say whatever, pick number one? Is it going to be 70, whatever? But from past experience with other surveys, people tend to go towards the high numbers. Yep, I love I love this service. So they usually pick 4 or 5. And so I sort of said, okay, so let's say 70% of the population are actually going to take this particular number, 1, 2, 3, 4, 5. So then what does that do to the sample size? As you can see in the middle table, all of a sudden the sample sizes are smaller when 70% of the population respond with a particular item. So when I said to each of the different sites, you know what, try to get sort of between 70 and 80 people, and that should give me enough numbers. So the good news is in August, so that's the next slide, I received actually data from both sites, and in one site I got 70 people to answer, and in one site I got 75. So I knew, you know what, I got enough data to start digging around in through here. So I tend to do my analyses in SPSS. Of course, you can use anything, including Excel, to do these statistical analyses. But what I think the main point of what I'm trying to say is, make a picture, graph your data, and that will often give you a lot of information. Now, as I've said earlier, this is fake data. These are not real data. This is from another study that I was involved with. So you can see from here that when I ask people to sort of select 1, 2, 3, 4, or 5, and depending on the anchor, the 1 could be not at all, and 5 could be always, whatever. So this graph shows, first of all, that there were no missing responses, and that 28 out of the 67 patients, or 41.8%, selected whatever option 5 is, 27 or 40% of patients selected 4, etc. So you just look at that graph and you go, you know what? Most of the people selected 4 or 5, and there wasn't anybody who didn't answer the question. There was no missing. The missing will often indicate people didn't complete or circle the number because maybe they didn't understand the item. So you also take a look at missingness and take a look at were there any patterns from that. So there's also a tendency for people to just say, oh, geez Louise, I'll just circle 5 for every single one of these items and be done with it. So one of the next things that I did was, as I said, for each one of the items, let's look at these different graphs, and then how can we compare the data? So are people sort of varying their responses and going, you know what, this one really is a 3, nope, this one really is a 5. And there's a bunch of different ways that you can do all of that. And one of the ways is to certainly look for averages or means, and you can take a look at their standard deviations, their variation. But when you're doing those tests, they assume a bell-shaped normal distribution, and that's that little U that's in that graph. And you can see by just looking at it, you know what, that does not look like a bell-shaped curve. There seems to be a whole lot more going on the left than on the right-hand side. And so then you sort of go, at least I actually tested. So that's the Shapiro-Wilk test. So that tells me it is definitely not normally distributed. So then you can't use the tests that you usually hear about, like t-tests that assume this normal distribution. There's a whole bunch of non-parametric tests. I'm not going to go into which ones I specifically use, but then what we took a look at was, yes, the scores did vary item by item. People didn't just circle 5 every single time. Good thing. So on the next slide, what you can see then is what I said was, I wonder if the findings are different from the one site to the other site because they're delivering different programs. You want the tool to be able to pick up differences when differences truly exist. Once again, these are fake data. So on site 1, you can see that, and site 1 out of interest in this case is 54 people, that 24 people selected 5, 21 people selected 4. So there's more people selecting 5 than 4. At site 2, it kind of looks a little bit different. It looks like more people selected 4 than 5. So just by even looking at those, you sort of say, it looks like there might be a little bit of a difference. So what I can tell you is when I did a statistical test, and in this case, it's called a Mann-Whitney-U test. Don't need to know the details, but they actually weren't statistically significantly different. And part of the reason for that is because in this particular situation, my site 2 only had 13 people. You saw with the previous slide with the sample size stuff, 13 isn't going to give me the ability to detect more than like, oh my God, differences between the 2 sites. But anyways, by just looking at those numbers, let's say you really said, I want the greatest number of people selecting 5, fabulous or excellent or whatever that anchor is. And you can see in site 1, there were more people who selected 5 than any other group, but in site 2, more people selected 4. So that would again be one of those aha moments where you go, maybe there's something else to do and think about at site 2. So then, and the next slide, what we did is I looked at the psychometric properties. And psychometric properties means what's the reliability and the validity of the tool. The reliability is the degree to which a tool produces stable and consistent results when no change has occurred. When you're sort of putting darts on the dartboard, are you kind of hitting the same spot most of the time? There's a whole bunch of different ways of testing for reliability or consistency. And you may have heard of things like test, retest, inter-rater reliability. What we did this time was internal consistency. We used a statistic called Cronbach's alpha that basically says, how closely related are this set of items as a group? And the numbers that we saw was that the tool actually had good internal consistency. The items actually hung together. Validity says, are you actually measuring what you think you're measuring? And in this case, are you really measuring patient experience? Face validity says, at face value, are you really measuring patient experience? And so when we gave the tool to the experts in the field, when they looked at all the items that we had, they went, yep, that actually covers the multiple aspects of patient experience from what we know as clinicians and experts. We also gave the tool, as you saw through the cognitive interviews, to patients. And they said, yep, that also, when taken together, describes what my experience was like. And of course, we expected that because it was framework dependent. And so we knew we had covered all the key domains as identified by Wong and Haggerty. So none of the tests also seem to demonstrate, you know what, you've got, this number of items. Maybe if you cut it down, it would be better. No, we needed to keep all the items as well. So we now have a tool that we know from the numbers perspective is reliable and valid. But we also collected words, qualitative data. And so, of course, that's on the next slide. We got comments, things like, oh, no concerns, everything went very smoothly. We also received tons of comments, as you all do, about the parking charges are too much, the room was too cold, the room was too hot, things that the program can't control. But we also received a number of comments that were specific to the program. So for example, something like, why was the appointment 2.5 hours? I was just so tired when I left. So what we did is we took all the comments, and we got a lot of them, and we sort of said, so do they hang together? Where are the themes for all of this? And what was really interesting was that the qualitative comments really seem to hang very closely to the Wong and Haggerty framework. So for example, somebody could have said, I wish the phone wasn't so busy when I tried calling. And you can see that that aligns very nicely with the Wong and Haggerty theme of access. Can I actually access people and the program? So we theme the data, and again, everything seemed to fit nicely with the framework. So in conclusion, what I would say is you need to use both the item level frequencies, the numbers, and then you take a look at the words, the qualitative pieces. And then I think with that rich and comprehensive data from both those aspects, you can actually take a look at where should you be thinking about improvements. So that really was highlighted for me when we took the findings to the key stakeholders. So we shared all this information with the Regional Geriatric Programs of Ontario Executive. And when we said these data, they went, oh my gosh, I wonder if at my site we could. And so I think the findings, again, are amenable to further discussion, further ideas regarding what could be improved, as well as identifying areas of excellence. So, all these numbers. What the next thing I'm going to do is ask you a question. So we're going to go now to the polls, and we have a question for you. So our question is, have you implemented or been part of a team implementing a quality improvement initiative based on information from any kind of patient survey? Have you? Yes, or have you not? No. I feel like singing the Jeopardy theme song now. So 45% of you have said you've actually used the findings from a survey to develop a quality improvement initiative, and 55% of you have not. Thanks for sharing that bit of information. So now on the next slide, so based on the information that we got from the patients during the cognitive interviews, from the clinical and research experts, from provincial and committee members, as well as from the pilot sites and the analysis that I just spoke to, we made a few revisions. So first of all, the size of the qualitative feedback box was increased to be respectful of the patient's comments. We wanted to make sure that the patient had enough space to express what they really needed to. Remember, we used a legal size piece of paper, hoping that one piece of paper, then they wouldn't have to worry about turning over and worrying about them not completing things. But we wanted to give them lots of space. So now we've got we suggest that you use we want you to use a 2-letter size pages. The survey introduction and instructions were also made more concise. There was one particular item that then we refined. So it had the highest proportion of missing values. And so we said, I wonder if it's because people aren't understanding the wording here. As well, on the pilot site, we had 3 categories of who completed the survey. We saw who selected what, and we've now got that down to 2 categories. We also then added 2 other elements following the completion of the pilot. We have written instructions now for returning the survey. We also added demographic data at the bottom of the survey tool to say, let's find out if these differences are important by gender or by age. So in addition to revising the actual survey, we made 2 other changes. So the processes we used to support data collection, so we noticed that there wasn't a lot of people completing the date of the survey. So did we know whether it was a March or an April or a May person completing this? And we wanted to know more about who completed the survey. Those were 2 elements, again, that seemed to be more missing. So now we have processes used to collect that. And we also want to know a little bit more about response rates. Are some people who are being given the survey tool just leaving and not filling it out? Or is everybody who's being given the tool actually completing it? So that's my section. And now I'm going to turn the presentation back over to Renee.
Thank you, Iris. All right, so let me see here. Oops, did I go back too far? There we go. Summary of learnings. So, okay, we learned a lot while we were doing this over the 4 years. Excuse me, we never anticipated that it would take 4 years. So the process of receiving REB approvals at various sites took way longer, particularly at one site. But and it required different degrees of information with different processes and response times. So altogether proved to take much more time than we initially thought. So the second one here is that having the regional and provincial SGS experts engaged from across the province that were skilled in the clinical methods, research, performance measurement, evaluation was extremely vital to the success of this project. And at this point, I actually want to make sure to thank every member of the working group for their work and help with that, and anybody else that we touch from the pilot sites as well. I think I mentioned that later on as well, but I just really want to bring that home. Number 3, so engaging patients and caregivers in the cognitive interviews. In retrospect, should be skilled in clinical, we should include patients and caregivers earlier than we did in the process. So we engaged them in cognitive interviews, but maybe if we could have had them on the committee, but that just wasn't the case at for this particular survey. So for building relationships with colleagues across the province via teleconference calls took more time and would have been easier if we were meeting face to face, but we just did the best we could, and it's just not enough resources, time or money to have us meeting across the province in one location on a regular basis. So it took a lot longer to do this because of this. So building relationships was great, but then having a structured process for decision making was absolutely key. So that collaborative approach that I talked to earlier, really important to have that, especially trying to build that collaborative provincial approach. I think one of the things is don't take time to reinvent the wheel. We ended up building off of work that was already done, and that saved us a lot of time. But it was evidence-based. It was nationally recognized. If it's out there, why not use it? Why reinvent it? And we started with the end in mind. We knew we wanted a reliable and valid tool for patient experience, and we wanted to be able to collect the voice, get the collective voice of geriatric patients so that they could be heard provincially. And we're really hoping that we're going to be able to achieve that. So it depends on some of the next steps, I guess. So the next steps, I'm going to go into that next. I'll click here. Here we go. So next steps, complete the development of the implementation guide. So we've started developing an implementation guide to accompany the patient experience survey. There's a lot of details for this, and we want to make sure that everybody really understands all the different steps and what to do and what to include. So number 2, it's our intention to make the survey and guide available at no cost to those who want to use it. We're currently in the process of preparing a manuscript to submit to a journal. I think Iris talked to that already, because we want to increase awareness and support use. And also, as one of the initial objectives was to create a collective voice for patients, it's important that a process to upload data from SGS programs across the province, that we can explore that. If we aren't able to do that, we will not be able to reach that goal of that ultimate collective voice for patients in the province. So then, as part of, as our province is multicultural, we really hope that we can bring this in, in different languages. Right now it's just in English, but obviously there's a need to do that. And you would have thought that after 4 years, because that's how long it's taken, to do this patient experience development work, that we'd probably want to take a break, but no, we didn't. Last year, we completed a literature review for caregiver experience survey, and we developed a framework from that lit review, and we're currently identifying core survey items with the help of caregivers. We recognize that it's important to have caregiver experience as well as patient experience. So to have surveys for both for SGS is ultimately our goal. So it's been a long journey, but I hope that this gets used, and that we can actually have it used across the province. Would be amazing. So I want to thank again. Here's a list of the members of our working group and our pilot site leadership. I also want to thank again the RGPs of Toronto for creating this opportunity for us to present today. Wendy Zay and Alikia Johnson, who also helped to make this webinar happen. So. And then we have one more poll question that we'd like to add here. And so if we could bring that up right now. So are you interested in receiving the patient experience survey and the implementation guidelines once they become available? So if yes, just click yes or no. And if you do end up answering yes, please take the time to enter your email into the chat box after we've done this poll. Or send an email to myself at rgilsonen@toh.ca. So you can see that in a minute. You'll see that in the next slide, stating your interest. And as soon as we've got the survey and the accompanying implementation ready, we will send it out to you. So we're just waiting now, see what the results. All right, 94% are saying yes, you'd like to receive that. So that's wonderful. Please do put your name into the chat, your email into the chat box, and if you're comfortable doing that, and that information will be forwarded to myself, and or send me an email. And here are the references for the different presentation aspects that we talked about today, different research, thank you, and some additional resources that are out there from Health Quality Ontario, CIHI, and the OHA. And thank you so much. My name, Rhonda. There's our names and our email addresses, and there you go. So thank you very much for attending today. And I guess this is the opportunity to get your feedback and get some questions. So I'll pass that over to Wendy.
Wonderful. Thank you so much for this presentation and sharing this innovative new survey with us. We do have time for questions, so I would encourage people to please type in the chat box. Please type any questions that you have so we can have our presenters answer them right now. I'll get the questions started. I'm wondering how soon we can look forward to the availability of the survey and the implementation guide.
That's a very good question. So we are building that right now, and And actually, any feedback that we get from you today with regards to any questions or whatever, we want to make sure that we're going to answer your practical questions. But we're hoping that we'll have that for you in the next month or so. But we want to make sure that it answers all the questions and that we really get the final version of the survey to you as soon as possible. We recognize that there's a fair amount of urgency out there to get access to this.
I'd say urgency and interest for
yes.
sure too. This is great work that you've done, and such a vigorous and rigorous process in terms of what you've done here. We've got a question here. Did you find a difference in pilot sites depending on the geriatric program availability?
So a difference in the pilot sites as far as the different types of programs being engaged, is that, I guess that's what the question is. Yes? Anyways, there were differences. So we basically, we did see some differences. And I don't know, can I pass that over to you, Iris? Did you see any differences between the pilot sites?
Absolutely, and that was one of the, again, key things that we wanted to know was although people do tend to score 4s and 5s at the high end, what they sometimes call ceiling effects, were there differences by site? So as you heard, one was a day hospital and one was sort of a clinic home visit combination, the GAIN team. And yes, we were actually able to pick up specific differences by the sites. So the information could be both used at the site level as well as rolled up.
So I hope that answers that question. Any more questions?
The person who wrote the question just clarified, yes, we are a very small hospital. I think that was what the context was there.
So one of the challenges there is if you're a smaller hospital with a fewer number of people that you're seeing, then I think there is a challenge to figuring out, do you want information from absolutely everybody or do you want to get a sample? And I'm not going to start really addressing all of that, but it depends on how comprehensive the data are and what are you going to do with them.
Well, that's an important point too that you mentioned, Iris, and as we noticed in the poll, it was 50-50 in terms of people who had implemented a QI initiative based on information from the pilot survey, and it's so important, from a patient survey, and it's so important to make sure that we do action the patient information that we receive, isn't it?
Wendy, thank you for bringing that up. I think that's, again, one of the reasons why one of the recommendations is that we get patients involved and their caregivers very, very quickly. It's the patient voice, it's the patient experience that is fundamentally important. Health Quality Ontario has certainly been highlighting that through all their documentation. And one of the key bullets that they have is they say, recognizing that patients are experts about their own experiences over the entire journey of care is fundamental to understanding whether or not the health system works. So I think it's very important to hear that patient voice and then to understand how we can make changes that is going to make that experience better.
Absolutely. So we're coming up to the top of the hour. We don't see any more questions in the chat box, but we do encourage people to feel free to email you. Your email addresses are right there. And we'd like to thank you again, Renee, Iris, and Rhonda, who is in the presentation but not speaking, for this wonderful information. Thank you to the audience too who attended today, and we encourage you to take a few minutes to complete the quick survey that will be emailed to you after today's webinar. And we'd also like to invite you to attend our upcoming webinar on April 26th from 12 to 1. And it is a collaborative approach to the prevention and management of delirium, the Medical Psychiatry Alliance Adult and Seniors and Patient Delirium Project. So